Heart sounds. The heart sounds coincide with closure of the heart valves. Closure of the valve leaflets causes the valve intracardiac blood and the heart walls to vibrate. This mechanical energy is transmitted through the chest, producing an audible sound. Opening of the valves is a slower process and cannot be heard with a stethoscope. There are 4 heart sounds. The first and second are described as lub-dub and are easily auscultated with a stethoscope. The third and fourth heart sounds usually indicate pathology. So the first heart sound is S1. It is described as closure of the mitral valve and tricuspid valves, and it marks the onset of systole, the end of left ventricular filling and beginning of isovolumetric contraction is occurring. The volume proportionate to force of contraction. So the volume is proportionate to the force of contraction. The sound is louder with vigorously contracting ventricles, and the sound is softer with poorly contracting ventricles. The second heart sound is S2, and it is described as the closure of aortic and pulmonary valves. It marks the onset of diastole, the end of left ventricular ejection, and beginning of isovolumetric relaxation is occurring. The volume is proportionate to left ventricular pressure decrease at the end of systole. So volume is proportionate to the left ventricular pressure decrease at the end of systole. The sound is louder with hypertension, the sound is softer with hypotension. The third heart sound is S3, and it suggests a flaccid and inelastic heart. So think heart failure. It's heard during the middle 1/3 of diastole after S2. It is described as a gallop rhythm, described as a rumbling sound. The fourth heart sound is S4, and it's caused by atrial systole. It's heard directly before S1. So where should you listen? You should know where to listen to each valve. We've illustrated where you should auscultate the valves to assess their normal function. Where a particular valve is heard best is not directly over it, but rather a function of how the blood vibrates and the direction of the sound waves that are transmitted through the chest. See the picture to the right. The aortic is a reddish pink, the pulmonic is a blue, the tricuspid is green, and the yellow dot is for mitral. Concentric and eccentric hypertrophy. The atrioventricular valves, the mitral and tricuspid, separate the atria from the ventricles. The valve leaflets are anchored to the interior of the ventricles by the cordoni tendineae and papillary muscles. These structures prevent the prolapse of the atrioventricular valves during ventricular systole. The semilunar valves, aortic and pulmonary, open to let blood flow out of the ventricles. The valve leaflets are not anchored to cordoni tendineae or papillary muscle. So when a valve opens, blood is propelled forward by a pressure gradient created inside a cardiac chamber. When a valve closes, blood is prevented from moving backwards. The following are mechanisms of valve failure. There are basically 2 ways that a valve can fail: stenosis and regurgitation. Stenosis is a problem where there is a fixed obstruction to forward flow during chamber systole. This requires a higher transvalvular pressure gradient. Regurgitation is a problem where the valve is incompetent, so some blood flow flows forward and some blood flow flows backward during chamber systole. The following is a diagram that depicts regurgitation and stenosis. A valve lesion can be a primary due to a problem with the valve itself, or a secondary due to structures such as supporting structures or ventricular dilation or papillary muscle infarction. So, a valve lesion can be primary or secondary. Sometimes a valve will have elements of both stenosis and regurgitation. Management targets the lesion of greater hemodynamic significance. Stenosis is pressure overload and leads to concentric hypertrophy. There's a fixed obstruction to forward flow. In order to overcome the obstruction, the chamber must generate a higher transvalvular pressure gradient. Blood flow passes through a more narrow opening, i.e., higher resistance, and becomes turbulent and travels at a higher velocity. The heart valve compensates by adding sarcomeres in parallel. The chamber walls become thicker. This reduces the radius of the chamber. The following describes regurgitation, which is volume overload leading to eccentric hypertrophy. The valve is incompetent. When the chamber contracts, some blood flows forward and some blood flows backwards. During chamber diastole, there are two quantities of blood entering the chamber: blood returning from circulation and the regurgitant fraction. This causes volume overload. The heart compensates by adding sarcomeres in series. To accept a larger volume, the chamber radius increases, meaning the chamber dilates. So to review, stenosis produces hypertrophy by adding sarcomeres in parallel, whereas regurgitation compensates by adding sarcomeres in series. The following depicts the sarcomeres being added in parallel and series and how it affects the radius of the ventricular tissue. Aortic stenosis overview. The normal valve orifice is 2.5 to 3.5 centimeters squared. Aortic stenosis is considered severe when the valve orifice is less than 0.8 centimeters squared. The most common cause of aortic stenosis is bicuspid aortic valve and calcification of the valve leaflets. Other causes include rheumatic fever and infective endocarditis. Pathophysiology. Aortic stenosis is the result of obstruction to blood flow across the aortic valve. Since the heart must generate more force to eject its stroke volume, it suffers from pressure overload and elevation in wall tension. Remember that an increase in ventricular pressure will present as an increase in height on the pressure volume loop. Also note that the end systolic volume is higher as a function of elevated afterload. Replacing the aortic valve has several benefits, including decreased afterload, decreased left ventricular aortic gradient, and decreased left ventricular end systolic volume. In accordance with the law of Laplace, the left ventricle compensates with a concentric hypertrophy. This produces a thickened left ventricular wall with a decreased compliance in a narrowed chamber. Over time, this adaptation reduces myocardial oxygen supply, i.e. subendocardial compression, and increases MVO2, myocardial oxygen consumption, and this increased heart mass is responsible for this. The patient will experience myocardial ischemia, left ventricular failure, and pulmonary edema. In this diagram on the left, you'll see the pressure volume loop depicting aortic stenosis, and on the right, you'll see the hemodynamic changes that result from aortic stenosis. A way to remember the symptoms, which are a triad of aortic stenosis, is to think, we find it sad, SAD, that the triad syncope, angina, and dyspnea on exertion is the classic presentation of severe aortic stenosis. The 50% survival rate for each of these symptoms is 3, 5, and 2 years, respectively. So syncope, you have 3 years, angina, you have 5 years, and dyspnea, you have 2 years. So again, SAD represents syncope, angina, and dyspnea. Syncope is 3 years, angina is 5, and dyspnea is 2. Patients usually remain asymptomatic until after left ventricular dysfunction develops, so one should always listen for the murmur of aortic stenosis, particularly in the elderly, and also before performing a subarachnoid block. The following describes anesthetic management. The heart rate and rhythm should be 70 to 80 beats per minute and maintain normal sinus rhythm. A properly timed atrial contraction is absolutely required to prime the non-compliant ventricle. The loss of atrial kick, such as junctional rhythms or AFib, will reduce ventricular filling and cause a decline in stroke volume. Tachycardia decreases the time for ventricular filling, which decreases left ventricular and diastolic volume, which decreases stroke volume, which decreases cardiac output. So, you may have to cardiovert, and if you do, make sure you synchronize. But you can also try a beta blockade. If the heart rate is 70 to 80 beats per minute, drugs that increase heart rate further should be avoided. Bradycardia results in decreased cardiac output, which results in left ventricular overdistension with compression of the subendocardium, and this decreases myocardial oxygen supply. Obviously, if the patient is bradycardic, you'll have to increase the heart rate. Use atropine, glycopyrrolate, or ephedrine. Regarding preload should be increased. Adequate left ventricular and diastolic pressure is required to fill the non-compliant left ventricle. Left ventricular and diastolic pressure and pulmonary artery occlusive pressure overestimate left ventricular and diastolic volume. So, administer IV fluids to ensure adequate intravascular volume. Systemic vascular resistance should be maintained or increased. Stroke volume is fixed by the stenotic aortic valve, and therefore cardiac output is dependent on heart rate. Remember that blood pressure equals SVR times cardiac output. Hypotension leads to decreased aortic root pressure, which leads to decreased coronary perfusion pressure, which causes myocardial ischemia. Other anesthetic considerations include hypotension, which should be treated with alpha-1 agonists. So low blood pressure should be treated with phenylephrine or some other alpha-1 agonist. This will increase SVR and coronary perfusion pressure without increasing heart rate like ephedrine does. Chest compressions during CPR won't generate sufficient intracardiac pressures to overcome the stenotic aortic valve. Stroke volume and cardiac output will be inadequate. Remember that afterload is set at the valve, so valve replacement greatly improves afterload. Since the impedance to left ventricular ejection, i.e. afterload, is reduced, the heart ejects more of its volume, so stroke volume increases. Said another way, left ventricular and systolic volume will decrease. Contractility should be maintained. It's usually not an issue until late in the disease. Anesthetic considerations include inotropes if left ventricular dysfunction occurs. And pulmonary vascular resistance should be maintained at normal, so it should be normal. It's usually not an issue until late in the disease. Diastolic failure increases left atrial pressure, which leads to pulmonary congestion and dyspnea. Regarding regional anesthesia, spinal anesthesia is avoided with severe aortic stenosis, i.e. a valve area less than 0.8 centimeters squared. This is because a sympathectomy rapidly reduces SVR, leading to profound hypotension, reduced coronary perfusion pressure, and cardiovascular collapse. Epidural anesthesia with a slower onset local anesthetic creates a more gradual sympathectomy. This decision should be made on an individual basis and is reasonable as long as the patient doesn't have severe aortic stenosis. A lower block height is less likely to create hemodynamic instability. The following depicts arterial waveforms. The left is a normal waveform, and the right is aortic stenosis. Notice the dampening of the dicrotic notch. When contrasted with a normal waveform, the arterial tracing of aortic stenosis exhibits a lower systolic upstroke, meaning pulsus tardus, with a delayed peak. Stroke volume is typically reduced in aortic stenosis. This creates a narrow pulse pressure with a waveform that has a small amplitude. This is called pulsus parvus. The dicrotic notch may not be present, and the overall impression may be of a dampened waveform. Mitral stenosis. The normal mitral valve orifice is 4 to 6 centimeters squared. Severe disease results when the valve area is less than 1 centimeter squared. The left atrial pressure to left ventricular pressure gradient exceeds 10 millimeters of mercury, and the pulmonary artery systolic pressure is greater than 50 millimeters of mercury. Asking about the most common causes of mitral stenosis is tricky. In the United States, the incidence of rheumatic fever is quite low, so the most common cause of mitral stenosis is endocarditis and calcification of the mitral annulus, secondary to atherosclerosis. In developing nations, rheumatic fever is the most common cause of mitral stenosis. Other causes include rheumatoid arthritis and systemic lupus erythematosus, congenital defects, left atrial myxoma, carcinoid syndrome, and iatrogenic following mitral valve repair. Pathophysiology of mitral stenosis is the result of an obstruction to blood flow across the mitral valve. Early in the disease, increased left atrial pressure is a sufficient pressure head to maintain left ventricular filling. As the valve orifice narrows even more, the pressure gradient between the left atria and the left ventricle increases, and the left ventricle becomes chronically underfilled. We have an overfilled left atrium and an underfilled left ventricle. In addition, we have a lower end diastolic volume, stroke volume, and cardiac output. See the pressure volume loop. The body compensates by increasing systemic vascular resistance to maintain blood pressure. Again, blood pressure equals cardiac output times systemic vascular resistance. An increase in left atrial pressure and volume alters the anatomy of the atrial conduction system. This can precipitate atrial fibrillation. Loss of atrial kick reduces ventricular filling and reduces cardiac output. Surgical options for treating atrial fibrillation include the Mays procedure and pulmonary vein isolation. Increased left atrial pressure also creates a back pressure in the pulmonary venous system, contributing to an increased pulmonary venous pressure. Increased pulmonary vascular pressure promotes fluid movement into the pulmonary interstitium. This reduces pulmonary compliance and increases the work of breathing, resulting in dyspnea. Chronic pulmonary fluid overload causes anatomical changes in the pulmonary vasculature, leading to pulmonary hypertension. Pulmonary hypertension increases the workload of the right ventricle, eventually causing it to fail. This is known as cor pulmonale. Anesthetic management should maintain a full, slow, and constricted heart. Heart rate and rhythm should be the low end of normal for the rate and should be normal sinus rhythm. Tachycardia decreases diastolic filling time, which reduces the time for blood to pass the stenotic mitral valve. Increases left atrial pressure is a consequence. Anesthetic considerations are as follows. Tachyarrhythmias are treated with amiodarone, beta blockers, calcium channel blockers, digoxin, or cardioversion. Avoid drugs that increase the heart rate, such as anticholinergics, ketamine, or atracurium. Any condition that increases cardiac output or heart rate will increase the left atrial pressure and may lead to pulmonary edema. Clinical examples include thyrotoxicosis infection, autotransfusion during uterine contraction, in the pregnant patient. Preload should be maintained. The left ventricle is chronically underfilled. This decreases preload, which decreases stroke volume and cardiac output. Hypervolemia increases left atrial pressure, which leads to pulmonary congestion. Anesthetic considerations include diuretics that may be used to decrease left atrial pressure. The left atria undergoes concentric hypertrophy. Pulmonary arteriocclusive pressure overestimates left ventricular and diastolic pressure. The PAOP waveform may reveal a prominent A wave and a decreased Y descent. Regarding afterload should be maintained. In the setting of low stroke volume and cardiac output, the systemic vasoconstriction increases SVR and preserves blood pressure. A rapid decrease in SVR will elicit a baroreceptor-mediated rise in heart rate, and this is not good. Treat hypotension with a vasoconstrictor such as phenylephrine or vasopressin. Ephedrine isn't the best choice here. Maintain contractility. It's usually not an issue. You should avoid increases in pulmonary vascular resistance. Pulmonary hypertension increases the workload of the right ventricle. Avoid conditions that increase PVR, such as acidosis, hypercarbia, hypoxia, lung hyperinflation, nitrous oxide, and the Trendelenburg position. Regarding regional anesthesia, blood stasis in the left atrium is prone to thrombus formation. The rate of embolic phenomenon is 7 to 15%. Patients with atrial fibrillation will be anticoagulated to an INR of 2.5 to 3. Don't put a needle in the backs of these patients. If the INR is less than 1.5, neural axilla anesthesia can be a safe option and should be considered on an individual basis. Epidural anesthesia is preferred over spinal anesthesia due to the lower onset of sympathectomy. Mitral insufficiency. This occurs when blood re-enters the left atrium through an incompetent mitral valve during ventricular systole. This lesion is associated with volume overload and an eccentric hypertrophy. The following are etiologies of mitral insufficiency: rheumatic fever, ischemic heart disease, papillary muscle dysfunction, ruptured cordoni tendini, endocarditis, mitral valve prolapse, left ventricular hypertrophy, systemic lupus erythematosus, rheumatoid arthritis, and carcinoid syndrome. Pathophysiology. During normal ventricular systole, the mitral valve is closed and blood is ejected into the aorta. With mitral insufficiency, the stroke volume goes in two directions, towards the aorta and through the incompetent mitral valve towards the left atrium. This leads to volume overload of the left atria and left ventricle. The regurgitant volume is increased with a slower heart rate, increased pressure gradient between the left ventricle and left atrium, increased systemic vascular resistance, and increased size of the valve orifice. On the pressure volume loop of mitral regurgitation, note that the end diastolic volume gets smaller during isovolumetric contraction of the left ventricle, whereas it shouldn't change at all. We put an M there to help you remember this. Also, Remember that a pressure problem is depicted by an increase in the height, while a volume problem is depicted by an increase in the width. Last, the acute loop is always smaller than the chronic loop. So the following diagrams depict pressure volume loops of mitral insufficiency on the left, and then the actual valvular pathologies on the right with subsequent sequelae. And then on the left, you'll see the pathophysiology of acute mitral insufficiency versus chronic mitral insufficiency. So in acute, the systemic circulation is described as a decreased stroke volume, which decreases blood pressure, has an increased SNS tone, an increased systemic vascular resistance, and an increased mitral regurgitation, which again decreases stroke volume and leads to the cycle. In pulmonary circulation, an increased left ventricular end diastolic volume leads to an increased left ventricular end diastolic pressure, which increases the PaO2, which causes pulmonary edema, which leads to pulmonary vascular remodeling, pulmonary hypertension, and right ventricular failure. This is during the acute mitral regurgitation. During chronic mitral regurgitation, on the systemic circulation side, you have an increase in left ventricular end diastolic volume, which leads to eccentric hypertrophy, which leads to increased stroke volume, which leads to maintenance of cardiac output. That's in the early phase of chronic. In the late phase, you have a decrease in stroke volume, a decrease in blood pressure, an increase in SNS, an increase in SVR, and an increase in mitral regurgitation, which then feeds back into a decreased stroke volume that perpetuates the cycle. So that's for systemic circulation on the chronic side. For pulmonary circulation on the chronic side, you have a left atrial hypertrophy, which may lead to atrial fibrillation. It increases the left atria compliance. It maintains a normal PaO2. That's early in the chronic phase of pulmonary circulation. Late in the chronic phase or stage of pulmonary circulation with mitral regurgitation, you have an increase in left ventricular end diastolic volume, which increases left ventricular end diastolic pressure, which increases PaO2, which leads to pulmonary edema, which leads to pulmonary vascular remodeling, which leads to pulmonary hypertension and right ventricular failure. Regarding anesthetic management, heart rate and rhythm should be maintained with a normal sinus rhythm and a high heart rate. Regurgitation occurs during systole, i.e., isovolumetric contraction, and a faster heart rate reduces time spent during systole, and this reduces the regurgitant fraction. Preload should be maintained or increased. Not all the stroke volume goes into the systemic circulation, so some is lost to the left atrium. A higher preload helps compensate for the lost volume. PaO2 overestimates left ventricular end diastolic pressure and cannot be used as a reliable measure of left ventricular filling pressure. The PaO2 waveform might have an enlarged V wave. This represents the regurgitant volume passing through the incompetent mitral valve. Afterload should be decreased. Blood flow through the path of least resistance is ideal. Systemic vasodilation promotes forward flow, while systemic vasoconstriction increases the regurgitant volume. Anesthetics considerations include following mitral valve repair, there is a risk for systolic anterior motion of the anterior leaflet. In this condition, the anterior leaflet obstructs the left ventricular outflow tract during systole. The systolic anterior motion is suspected or verified with TEE. Treatment consists of increasing intravascular volume and increasing afterload with an alpha agonist such as phenylephrine. Systolic anterior motion is very similar to hypertrophic cardiomyopathy. Contractility should be maintained. You should also avoid increases in pulmonary vascular resistance such as acidosis, hypercarbia, hypoxia, lung hyperinflation, nitrous oxide, or Trendelenburg position. Regional anesthesia. Sympathectomies reduce SVR, promote forward flow, and reduces regurgitant volume. Drastically reducing aortic diastolic blood pressure can compromise coronary perfusion pressure. Aortic regurgitation. In the patient with aortic insufficiency, a portion of the previously ejected stroke volume re-enters the left ventricle during diastole. This causes volume overload and an eccentric hypertrophy in the left ventricle. Additionally, since a portion of the stroke volume returns to the left ventricle, cardiac output is reduced. The size of the regurgitant volume is made worse by bradycardia because of longer diastolic filling time, increased SVR because of increased aortic left ventricular pressure gradient, or a larger valve orifice, the larger area for blood to return through. Aortic insufficiency is either a result of an incompetent valve or dilation in the aortic root or its supporting structures. Unlike stenosis, which takes decades to develop, valvular insufficiency can either occur acutely or develop over many years. In this patient that has an intact mitral valve, there will not be pulmonary symptoms. If the mitral valve becomes incompetent, usually from dilation in the mitral annulus, then an elevated left ventricular and diastolic pressure will reflect back into the pulmonary circulation, causing congestion. If cardioplegia is injected into the aorta, it will pass through the incompetent aortic valve and enter the left ventricle. In the patient with aortic regurgitation, cardioplegia must be injected retrograde through the coronary sinus or directly into the coronary ostia. On the pressure volume loop of aortic regurgitation, note that the end systolic volume gets bigger during isovolumetric relaxation. This is because the regurgitant volume is added to the blood volume entering from the left atrium. We added an A on top to help you remember this. Again, this is a volume issue. The pressure volume loop becomes wider. Like mitral regurgitation, the loop for the acute presentation is smaller than that of chronic disease. Acute aortic regurgitation. Acute AI leads to rapid cardiovascular instability. The left ventricle becomes acutely dilated and experiences an increase in wall tension and impaired contractility. The left ventricular failure may result. Acute AI is usually caused by endocarditis, but it may also occur from aortic root dissection from aneurysm or trauma. Regarding chronic aortic regurgitation, in the patient with chronic AI, the left ventricle has had time to compensate with left ventricular dilation, such as eccentric hypertrophy. The diameter of the chamber increases to a greater degree than the wall thickens. This normalizes the wall tension, which preserves stroke volume and contractility. The rise in left ventricular and diastolic pressure, coupled with the reduction in aortic diastolic blood pressure, decreases coronary perfusion pressure. As the left ventricle continues to dilate beyond the range of compensatory mechanisms, the wall tension and cardiac mass increase. This reduces compliance and contractility, ultimately culminating in left ventricular failure. Chronic AI develops slowly, so the volume-overloaded ventricle is better able to compensate for a progressively increasing regurgitant fraction. Conditions associated with chronic AI include valvular calcification, Marfan syndrome, Ehlers-Danlos syndrome, and ankylosing spondylitis. Anesthetic management should maintain a full, fast, and forward. Heart rate and rhythm should be increased with normal sinus rhythms. You want a faster heart rate with normal sinus rhythm. A faster heart rate reduces the regurgitant volume and increases the aortic diastolic blood pressure and CPP, coronary perfusion pressure. A slower heart rate gives more time for the stroke volume to pass back into the left ventricle instead of moving forward. This reduces cardiac output. Additionally, this reduces pressure at the aortic root and can compromise coronary perfusion pressure. Regarding preload should be maintained or increased. Some of the stroke volume is lost to the left ventricle, so avoid hypovolemia. Afterload should be decreased. Blood flows along the path of least resistance. An elevated afterload increases the regurgitant volume, while a lower afterload promotes forward flow. Phenylephrine and vasopressin aren't ideal choices. Contractility should be maintained. Left ventricular failure is treated with an inotrope or a vasodilator or a combination of both. Pulmonary vascular resistance should also be maintained. Acute left ventricular dilation stretches the mitral annulus. Left ventricular pressure will reflect to the left atria and pulmonary circulation. Pulmonary congestion will result. Regarding regional anesthesia, sympathectomy reduces afterload and will reduce the regurgitant fraction. The following is an arterial pressure waveform. In patients with aortic regurgitation, the arterial waveform has a sharp upstroke, a low diastolic pressure, and a wide pulse pressure. So the waveform has a sharp upstroke, a low diastolic pressure, and a wide pulse pressure. This is secondary to the ease of ejection followed by retrograde flow of blood towards the left ventricle. This arterial pressure waveform may also have a biphasic systolic peak. This is called Bispherian's pulse or Bispherian's pulse because of an additional reflective wave from the periphery. Pathologic murmurs. If you understand the cardiac cycle, and by now you should, it's possible to reason your way through this. Aortic stenosis occurs during systole. In the left ventricle, it generates a significant pressure to overcome the stenotic valve. Left ventricular pressure can exceed 350 millimeters of mercury. High velocity through a narrow opening creates a nozzle effect. Sound transmitted through the upper aorta and carotid arteries may be confused with carotid bruits. Sound can vibrate intensely to the chest and may be palpated as a thrill. Murmurs can decrease in intensity with very severe disease. Not enough flow passes through the aortic valve to make a sound. The mnemonic is ASSS. Aortic stenosis is a systolic murmur heard at the right sternal border. ASSS. Aortic stenosis, systolic, sternal. Aortic regurgitation occurs during diastole. The turbulent retrograde flow across the aortic valve produces a high-pitch blowing murmur. It's not as loud as aortic stenosis, and there's less of a pressure gradient. The mnemonic is ARDS. Aortic regurgitation is a diastolic murmur heard at the right sternal border. Aortic regurgitation, diastolic, sternal. Mitral stenosis also happens during diastole. Left atria generates increased pressure to overcome the stenotic mitral valve. Left atrial pressure can reach up to 35 millimeters of mercury. There is an opening snap followed by a low-intensity rumbling murmur. The mnemonic is MSDA. Mitral stenosis is a diastolic murmur heard at the apex of the left axilla. So the mnemonic is mitral stenosis, diastolic, apex, axilla. Mitral regurgitation occurs during systole. There's a retrograde flow across the incompetent mitral valve during ventricular contraction. There's a holosystolic murmur characterized by a loud swishing sound. This sound is very similar to aortic regurgitation but occurs during systole. The mnemonic is MRSA. Mitral regurgitation is a systolic murmur heard at the apex of the left axilla. Mitral regurgitation, systolic, apex, axilla.